Welcome to the Human Resources session of Beyond the Treatment Table. I'm Stephanie, your host for today's discussion with Tara Jo Manal and Sharon Dunn. Tara, why don't you start us off with a quick background and your role with the workforce studies?
Sure. So I'm Tara Jo Manal. Nice to meet you all. I'm a physical therapist also. I'm board certified in sports and orthopedics emeritus. I spent the first 30 years of my career at the University of Delaware. There, I was left as an associate professor, but my biggest responsibility was I was the clinic director and director of residency and fellowship training. And we had a full service clinic within the university. So we saw about 20,000 visits a year. So it's not gigantic. But we also were divided by sports and orthopedics. So half of the staff were board certified, sports and orthopedics and neuro and older adult. So half are board certified in geriatrics and neuro, and the other half are board certified in sports and orthopedics. And so I was in the clinic full time for my entire career. Then I spent the last few years at the American Physical Therapy Association, and in that position, I was vice president of scientific affairs. APTA has been doing work in workforce forever, and so I inherited quite a big portfolio of work that has already been done. And what we did from there was try to get a pulse, in particular after the pandemic. The pandemic changed things, and we needed to be very careful. We didn't project things moving forward based on older data because we didn't know how much the pandemic actually changed trajectories of things. So we kind of had to start in a version of scratch post-pandemic to really get a sense of what workforce data we could get and what we could project moving forward. And that's the paper that was sent ahead that people might already have read. It was specifically on that topic.
Yes, and I'm going to add that to the chat now in case anyone didn't get a chance to look at that ahead of time. Okay, Sharon, you're covering the debt to income ratio, the big, beautiful bill categorization, and inspiring young professionals to join the physical therapy profession. Out of those big topics for today, share a quick background on yourself and what you hope people take away from our call.
Okay, thank you, Stephanie. And it's nice to see everybody today. Thank y'all for signing in to participate in this conversation. I'm Sharon Dunn, and I'm the current dean of the School of Health Professions and Sciences at LSU Health in Shreveport. In that role, I oversee 10 academic programs from PA to PT, OT, speech language pathology. We also have a PhD in rehab sciences. Like Tara Jo, we have a fully functional faculty clinic in our building, and that is where I keep a finger on the pulse of residency education, but also current clinical practice challenges that relate to administrative burden, documentation, billing, credentialing, contracts with payers, and that keeps me apprised of the challenges facing private practice as well. We too have workforce challenges, even though we're connected to an academic program. In addition to those roles, I'm the Vice Chancellor of Academic Administration here at LSU Health Shreveport. And that is student financial aid, the registrar of the library, and our assessment and accreditation offices. Student financial aid was new to me in December of 2023. I'd always been associated with it through being a program director and a dean, but I really got into the weeds of student financial aid when I became vice chancellor because we had a crisis in our financial aid office. And I learned very quickly how complex and challenging financial aid is, but I also learned that the cost of attendance is not only tuition and fees, but also all of the living expenses, maybe childcare expenses, transportation expenses. The cost of attendance can historically has been whatever the institution sets with no limits. The big beautiful bill put limits on what would be allowable in federal loans. And I don't think that's a bad thing, honestly, because when I was APTA president, a lot of our strategic priorities were around the debt burden to the future of the profession against the stagnant payment for our profession. So there needs to be a balance between what we're paid and then what the cost of education is. So all of that rolled into I'm someone who cares deeply about the future of our profession. I've seen the applicant pool go down over time, while the applicant pool for PA has steadily gone up over time. I believe the best and brightest have a great future in our profession. It's still the best experience, I believe, of all health professions because of what we do for people. We get to make a difference in someone's lives when they're at their most vulnerable. And that therapeutic alliance that we have with patients is like none other. It's such an incredibly rewarding career. So I want it to be as healthy as it's been for the future generations. So that's my interest in being here today. And that was a mouthful, but love this profession and hope that we can identify some solutions going forward here today.
That was perfect to start off on a positive note on a heavy topic. So I recognize a lot of names here. I see Michelle and Jillian and Jennifer, and I think Sean, you've been with us a couple times. If everyone can turn their cameras on, if you're comfortable, if you're not driving or if you're eating lunch, that's okay. I think it's much more comfortable and feels like we're in the room and we know who we're talking to, if you have your cameras on. And if you have a question, if you have something to add, you could either throw your actual hand up or you could use the raise hand feature, and I will try to pull you off mute as quickly as possible. So this is more like a conversation. So let's do some quick interviews with everyone who's here. I want to have you share your contact information, your role in private practice. This is our HR discussion, so your main HR concern. And then do you agree or disagree with the categorization? I'm gonna ruffle some feathers starting off. So I'm gonna put those prompts in the chat and it's a lot to type. So if anyone wants to just pop off mute and say it out loud, you can do that too. Or I'll call someone up who. So I put my contact information on there. I think for me, I'm most comfortable if someone wants to chat about this topic. If you want to message me on Instagram, I'm going to answer faster than LinkedIn. I'm a practice owner. My main interest in HR is preventing burnout with the administrative burden. And I'm a little confused online with all the noise online. There's a lot of negativity around this categorization and a lot of confusion on how we should get involved. Anybody else? Thank you, Jen.
Hi, I'm Jennifer Schneiders. I'm in Jefferson City, Missouri. I have two small clinics in rural Missouri. I am on your private practice board of directors. I am, like many small practice owners, the everything, the CFO, the HR director, the compliance officer. I have a great staff that sees patients, but I also still see patients a few days a week. So same as Stephanie, I think there's a lot of noise, and I think like many things that are divisive and new and controversial, you see a lot of that noise in social media, and it's not always accurate information. And often I think it's kind of a knee-jerk reaction, like, oh no, I'm so insulted. Now my profession is, being changed and I'm not getting the credit I deserve. And while that may be the case, I try to not take a stance one way or the other until I really feel like I have all the information that I need to do that myself and not take Facebook's word for it. And I haven't done that yet. So that's part of why I'm tuning in today.
Perfect. Sean, do you have anything to share?
So I'm a private practice owner in Minnesota, and kind of the same thing. you do it all, right? As much as you can. I mean, there's times that you have great staff in places where you're utilizing them and they're helping you. And then for whatever reason, maybe they move or they leave, and then it's back on you, which is almost harder than if you would have just kept it all at the beginning. Because now if you're going to try to train somebody else in on that stuff, just for that chance of them leaving again, it's frustrating and it's difficult, and that takes time. And so, I think the management of the clinics is way different now than it was 20 years ago, I feel, as a private practice owner for myself, where it makes me wonder about staying, I guess, or not, or, what to do, where do you go from here? And then, definitely it's like, I don't understand. I mean, with the whole professional degree, graduate degree, again, sometimes it's just we're not the only ones in that category, nursing, other things like that, but it's just a frustration. People just have, I think, too much time on their hands that they need to switch titles of things. And then it does make, it makes it looks like they're discounting that value of what we are, which I think is the opposite of what we've been striving to do. So I guess that's a little summary there.
I appreciate you sharing, and we're definitely going to hit on some of those pain points. I'm going to pull back for a second and just do my quick reminders, get them out of the way. This series is every fourth Thursday, 1 o'clock. Our goal is to make this a place for practice owners, both inside and outside of APTA, to come together on the topic in focus. So we're following a calendar. This is HR. Next month is going to be finance. Then we have leadership. And I hope that I continue to see familiar faces here and it becomes a lot more collaborative. I'm going to share the In Focus page in the chat because there are a ton of other resources outside of this on this topic. And at the end of the call, there's a pop-up survey that we use to shape these sessions. If you've been with us for a while, you'll notice that they look a little different each time. One of the main areas of feedback was that people wanted more networking. They want collaboration in between these sessions. So that's why I'm asking you to share your contact information. If you didn't, drop an email or your social media contact, whatever you're comfortable with, in the chat. And this way you can connect outside of here. Okay, Tara, we're going to come back to you. Give us a quick overview of the trends and what is theoretically predicted to happen.
Okay. So big picture, when you're doing this modeling, the challenge with it is it's all guesstimates based on inputs that you put into a model, literally. So you can change the output of the model just by changing a number that you put in. So you're using like the best information you have on what is going on in the field. One of the ways that we did that was we actually did a survey before we did the model so that we could get a pulse on what was happening in the field, because we didn't even have great numbers on whether we were starting in a deficit. Are we already short PTs, or do we have enough PTs? And you have to tell the model, this is the right number, or this is too low or too high, what we have today. Otherwise, the rest of it falls apart. And we found out that we were what was perceived to be a shortage in 2022. And we were short about 5% of all physical therapists, which is at the time mathematically is like over 12,000 PTs. That's about what graduates each year. So just to put it in perspective, we're graduating about 12,000 a year and we were short 12,000. So we were a year's worth of graduates down. And then what we did with the model was we said, okay, well, let's assume some things, right? So in this model, they actually accounted for all of the major health conditions across the country, as well as poverty levels, access levels. That's all in the model, believe it or not. And trust me, I got schooled on this model. I can tell you a couple of times I'd say, well, couldn't we just do this? And they would like, well, then we'd have to change 32 other variables. I was like, my bad. Yeah, you're the economic people. Let me stay in my lane. Because I was so excited once you could manipulate things. I wanted to try so many new things, but we just didn't have the data for it. But what we did was we basically fooled around with the model. We said, what happens if nothing changes, right? That's status quo is what they call it. Then we are going to be short, 5% goes up to like 8% in 2027 and down to 3% in 2037. But like, we're going to be short. That's not enough. To do nothing is going to mean short. A lot of that is the baby boomers aging and needing more services. So that's why it goes down again in 37 but because we're going to lose some of those people and they won't be accessing the services. So our demand will go down a little bit and that'll help us. But we're in a deficit state the whole time. Then we kind of went back and said, okay, well, what if we graduate more people? Where would we be then? If we graduate 10% more people on a regular basis over all the next years, we can get closer to our need. That was one model that we did. Then we said, well, what happens if we actually get to this idea of universal healthcare for all, reduce barriers, everyone gets the best of the care? We have a significant deficit then. We take what we had and now go in the 20% down. Like it's a big, massive deficit because we need so much more healthcare in order to do that. So the point of the model was to say, like, this is how good or bad it could be over time. And that's really what those graphs show you. And that's what the model tells you. But there's really only one scenario in which we aren't in a deficit state. And so it really says to us, okay, well, that means workforce planning. Right? If you know that you're going to be in a deficit state in the future, then we want to do some kind of workforce planning. And so what is that? And so that really lends us to the conversation I hope we have today, which is what more can you manipulate in the short term while the longer term, bigger picture issues are managed? Because a lot of the stuff that changes, let's just choose those who enter the field. So graduates and foreign trained or internationally trained, what influences them are not short-term buttons. You don't just flick a switch and now you just doubled your graduation rate. That's just not how it works. So those issues are long-term solutions if they are manipulated. So we have to think about that as a long-term one. What are the short-term ones we can do in between? And hopefully we can get into that today.
Sharon, do you have anything to bring up on the long-term button before we talk about the immediate action items?
I wish that every person in this country had the amount of physical therapy in their lives that they deserve. And that as a long-term button speaks to Tara Jo's, if universal healthcare ever becomes a thing, and we were a part of it, we have a great shortage to manage. But I'm also of the belief that if you build it, they will come. Because every time we hire an additional physical therapist in our clinic, there becomes more than enough need to justify that additional physical therapist. As people learn and the public has a better understanding of what we do for their long-term health and functionality and participation, that demand is being developed through public awareness. And we have made strides in public awareness. That comes out in the data and some of the studies that APTA has done on public understanding of physical therapy. If we don't meet the demand that we've already created, other practitioners are coming in to take on those roles. And I think we are the best as in movement and in movement analysis and in all the things that keep people home and safe in their environments. And so I prefer to think of the glass half full. I believe we need to believe in what we do as physical therapists and the public's need for it. And I don't think we should shrink back because we think that arc is bending downward of need for our services, because we know there's so much more we can offer when we have the bandwidth to do it.
So for the solo practitioners or maybe the new business owners on here, there should be no fear of hiring. There's more than enough demand.
Oh, for sure. I mean, in fact, not only that, the work that we did in collaboration with a private practice academy demonstrated that the majority of the deficit seen in outpatient was growth. it wasn't that people were leaving and then they were having all these holes. It was that they were expanding and they needed more physical therapists than they had before. So one of the biggest drivers of the shortage, if you will, or vacancies is growth. And, I agree with Sharon in this also in the sense that we aren't even talking, and this model did not even consider, because we don't have the data to do it. We haven't talked about expansion of practice. We're not talking about being in every emergency room and, doing higher level primary care management of musculoskeletal conditions. That is going to drive demand even higher, and it reduces supply because we move people who are doing certain care now into those roles. Then that leaves their spot open. And we only calculated the stuff that exists today because we don't have the ability to guesstimate that with any real accuracy. Over time, we will, if we can study it long enough, but we can't right now. And so just realize every time we expand into a new area, we're actually creating a bigger vacancy, if you will, or a greater supply shortage if we don't match that with either care extenders as an option, or as Sharon even mentioned, giving up things that we used to do. That's happened throughout our history. I mean, there's things that we think about that we used to do. Chest PT would be a good example, right? Like respiratory therapists took over that work, and physical therapists. I'm not saying no one does it. I'm sure someone does it. I'll get a text, but it's just not the volume of work that it was before, because respiratory therapy took that role as we moved out of that.
Sharon, do you want to speak to that portion of things at all? I know you have some thoughts on care extenders.
Our natural care extender is the PTA, and we have probably a great opportunity to get better and more effective and efficient at teaming with our PTAs, and that's important to increasing access to our services, particularly in rural communities. But we also need to adopt technology as soon as it's available, because virtual options, telemedicine, and opportunities to increase access to our services are moving rapidly as technology expands. And instead of being resistant and reluctant to embracing these technologies, there's nothing better than a physical therapist involved in using these technologies so that more people can access our services, because virtual access is better than no access to a physical therapist, especially in rural communities. I'm thinking about Louisiana. We have pockets of concentrated areas of physical therapists. It's where the schools are, where people end up practicing. But across rural Louisiana, there's absolutely no access to care. And if you think of a hybrid delivery model of care, they can come in, but if they live 45 minutes, 2 hours away from any clinic, then seeing them in person can be augmented with technologic virtual means as well. So I think those options are available, and we have a workforce coming in that prefers adaptable, flexible working conditions, and technology allows that as well. And don't compete with that. Bring that into your practice as an option for some employees to have a flex work environment. Maybe it's not all about bricks and mortar anymore. I tell students sometimes it's not your mama's practice, because technology allows us to use opportunities for people to access your greatest asset as a physical therapist is what's between your ears. It's your analysis of movement and your problem solving for patients to move better in their environments. And what's in your ears can be adapted through technology, and it's your communication skills that you use through technology to assist patients where they are. So I think necessity is the mother of invention, and as we get squeezed, it's uncomfortable, but it forces us to think differently, and disruption creates some of the best innovations. And that's been the case for our profession since the inception of our profession. So those are my thoughts right now. I might have told you in our pre-interview something else that I'm totally blanking on, but
That's that's exactly what I was looking for. And personally, I have that hybrid option, and I have a therapist who works 2 days a week from home because even though we're in New York City and all of our patients are walking distance from the office, there are people in upstate New York or out east on Long Island who want a therapist from New York City. So we can provide that access.
Stephanie, I want to add to that too. One of the things that we have to think about in that short leave, the short dials, not the long-term ones, are how do we either reactivate those who have left the field in smaller ways, and or prevent people from leaving. So that's a double, there's two different lanes there. And then what we also found was almost a fourth of physical therapists and physical therapist assistants are not working full time. Almost a fourth. So what does it mean to activate them 2, 3, 4 hours more a week? And again, these hybrid and these tele opportunities are really helpful for those who've chosen to stay home, those who are caring for another family member. These are the kinds of jobs that they can actually fit into their schedule. They can do it in the evenings. They can do it on the weekend when they are available and choose to, because they've made other choices inside the week. So I think that if we could take those that are deactivated, for lack of a better term, they're either not practicing or not practicing full time. Is that a place where we can maintain so much of that brain wealth and get access to people who need it, using these opportunities like telehealth as a great example?
Let's pause here. I want to hear, is anyone using these innovative models, or does anyone have any strong feelings about telemedicine or care extenders? I'm gonna call on the people with their cameras on because I know you're not driving. So, Nick, any feelings? Or okay.
Well, yeah, we do use it. We have a pediatric clinic, so it's maybe a little bit more beneficial for us in avoiding losing visits and such. So we were happy to see the extensions, of course, with Medicare and Medicaid as well. I'm in Nebraska, so I'm also the president of Nebraska. So also just monitoring it from a leadership standpoint.
Martina, anything?
I'm going to use it this next week because I have a patient that's going on, it's been a status post shoulder, and she's going to Florida. So she was all happy that she could still see me because she was so worried about going from active range of motion to resistance. So we have it all planned that we're going to do that now for the next 3 weeks. So I was excited that I could offer it. I have not done it. I'm a small private practice in Clarion, Pennsylvania, and I haven't done it since I left corporate and went into a private practice environment. So I'm the only one in here. I'm the only PT. I have a PTA working for me. So I'm excited to do it because I think it's another opportunity that I can make some of my patients happy when they're going on vacation. And then I had another one that was in here and she heard me offering it and she said, well, I want to do that too. I'm leaving. And so it's turned into 2 now. So I'm kind of excited that it's just something else I can keep some of the patients happy, and hopefully it works. I'm not a computer person, so hopefully I don't get frustrated with the computer aspect.
You're on a Zoom call right now, so not too different.
I know it should be the exact same way, but it took me like 20 minutes just because I can never find, I flag all of the training things, and I flag them and they never come back up in my calendar, and I can never find the Zoom thing. I don't understand why it's so confusing for me, but I have a really hard time. Then I have to re-register, and I am constantly doing this, and there has to be an easier
we
way
have
to
3
organize.
Martinas in our data. Are you skewing our data?
It's challenging.
Anyone else have feelings about, so I appreciate you're using both PTAs and telehealth in your model. Anyone else have strong feelings on, yeah, Lizzie, go ahead.
So, hi for those of you who I already know, and hi also for those of you who I don't already know. I do telehealth. I have a small private practice here in Baltimore City in Maryland. We do LGBTQ inclusive care, and so 60% of my patients identify as LGBTQ, and they really have limited access to care other places because some of the care they receive is not as unbiased as we would hope. And so telehealth can be helpful because people who are farther away from the practice may have even less access to care because they're not in the city. And if they're in a rural area, then the folks who are out there may not be as educated, especially on trans care and how to navigate that environment. So we do use telehealth. We use it for orthopedic PT and we use it for pelvic PT for our patients who often will come in for a new patient evaluation and then do some follow-up visits remotely because they're just too far away. We use, somebody's asking about platforms. We use Doxy. It's free. It is HIPAA compliant if you sign a BAA with Doxy and your practice. And a lot of EMRs are now building in telehealth, or sometimes your voice over internet provider can also provide telehealth. I know that RingCentral can do telehealth, and that is also HIPAA compliant. And I have a question about care extenders. Our local PTA program graduates like 6 PTAs per year. So we have really limited pool of PTAs to hire from. And my question is, in terms of like a non-licensed care extender, obviously people have used techs, and I used to work in a clinic that had techs help patients with their exercises. But what I've always been told is that in Maryland, you can't bill for their time. If it's not the PT directly supervising, then you have to bill group therapy and you can't bill direct codes. And my practice owners in my network in other states have said that's not the case in their state. They can bill one-on-one type treatment codes if a care extender, like an unlicensed care extender, is working with their patient. And the folks at my chapter actually didn't know if that language is regulated by the state or if it's per payer specific language. And I was wondering if anybody else knows what governs whether it's compliant to get reimbursed for an unlicensed person's time outside of the group therapy codes.
My answer is both.
Yeah.
Your state law, you must follow because your practice is defined by your Practice Act and the rules and regs governing use of care extenders. And then you contract with payers and you have to follow their policies as well. So one doesn't trump the other. You have to be compliant with both.
And it's whichever is the most conservative, obviously, in that case, but federally, right? So we know that there's federal guidelines related to PT contact, direct contact for payment, and that some of the other payers will adopt the same language and others do not. So it can be very payer specific. But Sharon's right, like then you can have a payer specific rule, but then your state may actually have a guideline or a rule. And I'm trying to remember what Maryland has as a one that I always thought was interesting, but I think you have a time limit, or there's how many patients you can treat per hour, right?
Like 3 patients per hour.
Yeah. And that's not true in every state. That's right. A Maryland thing. So you can see where the state will actually come forward and have their own guidelines, but it is generally payer specific. The answer to your question, it's not a universal yes or no.
Thanks.
But just can't help but throw in there. You can also reach out to the APTA because their billing and coding department is really super helpful. But just to throw out there, there is a significant responsibility for training, right? So that if you care extend to a non-licensed provider, that you've demonstrated that they have the skill and ability to do that. Some people, especially with turnover in those positions, that sometimes falls to the wayside and can be a real sticker.
Sure.
Yeah.
Could you put contact information in the chat for billing and coding folks at APTA, whoever I should reach out to?
Yeah. It's not, I got to think of it.
Alice Bell.
Well, I think it's payment@apta.org.
Okay.
I will ping Kat to find that for us. So.
Okay, I'm pretty sure it's payment, but I can try to get it if Kat doesn't.
Perfect. Thank you. Jennifer, did you have
They are
something to
very
add?
helpful. And that's one of the challenges of being a solo private practitioner, is keeping up with the legal and regulatory environment to be able to do everything within compliance.
Right.
And APTA certainly is helpful at managing that on your behalf and for you. APTA and PPS.
Right. And just to say, obviously, neither can give you legal advice. That's beyond their scope, and they'll say that, but then they can give you, really relevant information after that. But obviously they can't give individual legal advice. I did want to throw out there, though, a comment about telehealth, because this becomes also another place where regulation is really important. So during the pandemic, right, many states waived the requirement to be licensed in a state to treat an individual in that state. And that was across the board. So I got licensed in 7 or 8 states during the pandemic because our student population dispersed. And if they were home, we wanted to stay treating them through telehealth. And so our therapists got licensure in all different states, but it was under an emergency order. Most states, that order has expired. And so just be cautious about being licensed in the state in which the individual you're treating is currently be physically located. Otherwise, you can get yourself caught for treating out without a license because you're not licensed in that state, but the person's in that state. So I just caution you to make sure that people are checking those boxes. But that's another great time to say the compact. So the compact licensure through the Federation of State Boards of Physical Therapy is a very easy way to say, this is my home state, but I have patients who regularly, I was in Delaware for 30 years. So Pennsylvania, Maryland, New Jersey, they're right there. Spitting distance. And so for us to then have licensure in those states made a lot of sense, especially in a telehealth situation. And so in a compact situation, if their state is in the compact, the state that you want to have as a secondary licensure, it really does reduce your hassle in getting that license. And so it's definitely something to look into if you're doing cross state telehealth. Within the state, your license is perfectly fine, but cross state.
Since we're touching on some of the back end side of things, anything that we want to talk about on the burnout or administrative burden?
Eric has a point, and he put in the chat that he's very interested in challenge with burnout, and what I've seen as an academic, as our graduates go out into the practice environment, many times they are put in situations where they're seeing more patients per day. I'm talking on the order of 25 to 30. That challenges them not only in their clinical problem solving as a novice, but also in their ethical decision making. So when they're in those environments, they quickly burn out because they feel like they're treading water. I'm a believer in practice environment that is a learning environment, that professional development and mentoring, and it doesn't have to be an established mentoring program. It doesn't have to be a residency program. It needs to be a strong buddy system where these new graduates come in and they've got somebody that they can bounce things off of, because it can be very lonely right out of school when you're expected to take on the responsibilities of a seasoned practitioner. And I'm advocating for early career physical therapists to have a buddy so they don't get lost and burnt out and feel like they're drowning. And the learning environment can be something as simple as a journal club at lunch, where you talk about current trends or new clinical practice guidelines, and let them feel like they can lead, because they're learning all of this in school. And there's a lot that we, as I'm going to call myself seasoned therapists, can learn from these new grads coming out. One that they're techno savvy. They were born with this thing in their hand, and they know how to navigate all platforms. It's just natural to them. Two, they understand what current best evidence is. They don't necessarily know how to implement it or apply it. That's where a seasoned clinician can help them become more efficient at the application of the things. So I think I think to manage the current burnout situation, we need to go back to who we were when those of us who are seasoned came out. We had mentors who, as Charles Magistro told me before he passed away, the early career and the clinical students would sit at the foot of the master who would teach them effectiveness and efficiencies. And I feel like private practices don't feel like they have time to do that because you're meeting all of the crazy regulatory demands. But you could assign someone in your practice to be that person to bring in the early career and make sure they don't get lost in the challenges of everyday practice.
Yeah, I agree. And I'll add to, the evidence is not always throwing more money at something, even though that sounds unrealistic, like that's crazy. That of course, if you make more money, you're going to be more happy, more happy. But that's actually not demonstrated to be true in the literature in healthcare. Once you're meeting your needs, your basic needs, then the more money doesn't actually make the difference. But it's that mentoring and the ability to see a progress in your career. And so that's where I think this team on this call can be super creative, right? Because what would be a progress in your career potentially at a place where there's 17 physical therapists and 32 sites is going to be completely different than what you see with a 2 clinics and 4 physical therapists. So I think that you have to be really creative as leaders to say, what does it look like to create these career paths for individuals to keep them happy and motivated to stay with us? Because someone mentioned earlier, attrition is super expensive, right? Even if it's not that you did anything wrong, but the person's significant other moved and they had to move with them. I mean, you're back at square one, and the training and the investment is huge. So it really is about what does it take to help keep people. And we're seeing, I just recently read an article in healthcare in general, but there's 4 generations on average in single care provision of care. So 4 different generations are treating these patients together, and everybody wants something different. They're not looking for exactly the same things. And so I wish there was I could tell you, these are the 3 things, if you do, it's going to work, because it's just not available. It's going to be different for a small clinic than a large clinic. It's going to be different depending on where your location is. And it's going to be different on what that individual's passions are. And so I can't emphasize enough, get to know the staff. And as Sharon mentioned, find out what motivates them or what they're afraid of, and create a buddy or a mentor who can work with them on those things. And that is the thing that really gets the hooks in. It really isn't dollars, and it isn't just that the idea of reducing burden, we know would make things happier, but I think we have to be honest. If you had less to do, you'd see more patients. So we're going to reduce burden, but we're going to add patients into that spot. So the overall work isn't going to change that much. It's just what you get to do with that work that's going to change. That'll be great for the society because we'll have more spots for people to be seen. That's the great part. But when we reduce the burden, we're probably going to increase our productivity. And so again, how do we get at the burnout? Because that is tied to the productivity as well.
But PTs don't want to do paperwork.
I agree.
I'd love to hear from Eric, who posted in the chat that he's primarily working with to reduce burnout, and I want to know what he's learned through his pivot.
Hi, Sharon. Yeah, I actually, so I did make a pivot away from the clinic here just a few months ago, actually, and I've started working for a company that sells EMR. And really the part of the reason for my pivot away from the clinic was because it felt like the largest lever that you could manage, or that I could manage anyway, was helping with making clinicians more efficient. And I mean, Tara, to your point, when people become more efficient, they that probably will get filled with more patients. But really, I feel like PTs are a unique community in that there are a lot easier ways to make a living than pitching folks around in a hospital room or trying to do manual traction on a lumbar spine. And so people don't necessarily get into this career with dollars and cents in mind, but trying to find a balance between the administrative burden, the documentation burden, and feeling like you're able to be there and be present for each one of your patients. So, I'm still frankly trying to figure that out. But Sharon, you'd mentioned, mentorship. I think that's really important, not just for the new grads, but also for the established clinicians. I practiced for 15 years, and I caught myself in ruts every once in a while where I felt like I was doing a lot of the same things over and over again. So it's again, it's one of those things where trying to make a day in the life of a PT as engaging and as exciting and fulfilling as it should be, and it's a process that I'm still trying to figure out. So
Thank you for sharing. I was just curious.
mhm.
I like that we returned to the mentor-mentee relationship because I think what we were talking about right before everyone logged on was sometimes you get to that stage of burnout and then you don't feel like you have the energy to reinvest in the next generation coming in. So having the mentor-mentee relationship actually fuels you as well, even though it feels like one more thing.
Mhm. Yeah, I think the mentee can be it certainly will benefit, but the mentor I think can also can fill their cup up as well.
Yeah, sometimes I feel like I'm mentoring, but then I leave the conversation and learn that I was mentored. As a younger generation certainly has a lot to share. I learn more from them than I could ever provide.
I find that hard to believe.
Nah, it's
Hmm.
true. You should come visit and ask our people.
Keep you sharp. Um, Tara, is there anything that we missed on the short-term action items so that when we leave today, it feels like, okay, there's something I could do. Everyone has just as much positive energy as Sharon did when we started out.
Well, I will say the one thing I didn't want to not mention, because again, burden is an issue. And I think we can't pretend it's not. We have to keep talking about burden. We have to. There's a lot that can be done. When I think of being in a private practice setting somewhere, and I think of, look, what are my things I need to do, right? One is I need to make sure that I have a really good pulse on the people I have. And I understand what it is that motivates them that I can tap into to keep them happy and reduce as much of the burden on that side and increase their energy in the best way that I can. The second thing I think about is someone mentioned, we have only 7 graduates in PTA in our area, so it's really a struggle. Is really how do we actually increase the volume of people coming into the profession? And physical therapy assistant is a great example. Good news is the last year their applicants are up after having declined for multiple years. So we're seeing some kind of a turn, but those things are very tricky, right? So we want to keep that going. And we definitely want and need more physical therapy assistants. And so what is the kind of outreach that you can do in your area to entice people to go into that area so that you don't have 7 graduating, you have more? Because they have been, we just did a survey on pelvic health in particular, and pelvic health physical therapists with shortages, which they almost 84% said they had, felt that physical therapist assistants could resolve their issue, actually resolve it, not just help it, resolve it. So what is it that we can all do to encourage people to move into this field? And so that can be simply going and giving a talk. It could be getting involved with the scouts in your area. I mean, it can inspire those who are going on to, from high school to say, hey, have you considered this degree? It's a short investment as far as years compared to physical therapist, right? They're out 5 years, 4 to 5 years sooner, making on average $60,000 a year. Just think of that investment in themselves after a 2+ year degree. So it's. I mean, I don't understand why they're not knocking down doors, because it's a really good ROI. And so again, thinking what you can do about that. And the very last thing is policy and advocacy. That's not my thing, meaning I didn't spend my career doing much of it, to be honest. I'm a little allergic to some of that. I get nervous that it's not my comfort zone, but I donate so that people who know how to do it well can do it. So that's my way of giving back. But last year there were 30 state wins across the United States in physical therapy, 30. And I looked at what some of them were, and they're things like reducing burden on pre-auths, making sure that an extra thing in a certain state wasn't required anymore because it was additional to what any other state asked for. I mean, people in the field are slashing burden in their states. And so, reach out to your group, your state chapter, and find out what's their advocacy issue and how do I get involved? If you want to know what's happened, you can go to the APTA website, just type in state wins. And there's a website that's it's 30 things that happened last year alone. But they were, I would say 70% of them were on admin burden. So people are just changing it in their state. They're not waiting for, a wave of government changes. They're making it happen, inside where they practice. So those are the 3 things I think I'd be thinking as a practice owner of trying to move or leverage.
Sharon, I'm going to let you talk about how early we have to influence those career decisions. But before I do that, I want to see, Jane, do you have anything to add from your perspective in academics?
Me? Oh, thanks, Stephanie. I'm sorry I was late. I was so busy working, I wasn't paying attention to the time. So I missed the beginning, but I was lucky to hear Sharon talk at the Graham session. So I know that stuff. But, one thing I was thinking about, and I don't know what everybody will think, but we've spent a lot of time in academics talking about once people become PTAs, don't try to turn them into PTs. Like that's a bad thing, and we are really trying to be creative in, bringing more people into the profession all the ways. Like I'm so glad what you said. I do a lot of talks at high schools, and I talk to a lot of high schoolers, and I'm talking about PT and OT, and I'm not talking about PTA and OT CODA because we don't have it. But I'm going to do that more. So thank you for that, because, if you go to PT or OT or PTA, it's all good. And so, I think we are really seeing right now at Widener, we've got something called a pre-medical program. And we have diagnostic medical sonography and also RT, and we're looking at some other programs. And we got those because they were joint with Crozier, and then it closed. But I'm glad we have them, because what's happening is we have so many students applying for this pre-medical program for the first 2 years, and then we don't have enough spots for them to go into something that is either going to be certificate or associates or bachelors, which those 2 programs are. And I think I call them kids because, I'm getting older. These kids in high school, because they are kids, they're really looking for, I want to be in healthcare, but how do I get there a little quicker? And, respiratory therapy, you're going to come out and make over 100,000. There's such a demand. And so, I think that's one thing, just really trying to your point, get more people into PT and CODA school, but also, we're really thinking about how can we help the CODA and the PTA who want to get to PT school or OT school. I don't think that's a bad thing, that we shouldn't be really thinking about whether they're coming right out. Some may say, yeah, I want to keep going. How can you make that easy for me? How can I just get a bachelor's in a year and then get into your program? You all know I spoke at Graham Sessions. I am huge on 3+. How can we get these folks through shorter? I can't control what everybody's charging uh, for programs, but I can help to get students educated about there's quicker ways to get through, and I can help create those. So that's my big thing, is really exploring every model out there that's going to help folks get to us into our programs at either level, and also get them through quicker. That's what I'm working on.
Love that energy, Jane. And I agree with you on career ladders and credential stacking for people who otherwise can't afford to go to school for 7 years and go into that kind of debt. So we're working on some of those things in Louisiana. One is a hybrid option for our PT program. We're going to keep our bricks and mortar standard program, but we're offering in a community that doesn't currently have a PT program a hybrid option, so that people with family obligations or learning style differences have an option. But wouldn't it be great if PTAs could come out and work while they earn their PT credential, so that debt burden it doesn't have them strapped to a lifestyle of chronic debt over time, where I think a lot of the burnout comes from. I've heard a couple of my own colleagues tell future PT students, you might want to weigh that carefully. We need to be ambassadors for the future of our profession. And it is a wonderful profession based on what we get to do with patients. Is documentation and regulatory burden a challenge right now? Yes, but technology is helping us pull out of some of that. And our PT cast numbers have begun to trend upward again. And I'm glad to hear from Tara Jo that the PTA cast numbers are trending upward again, because people are seeing that this is an amazing opportunity to invest in others. It's a service. It's a ministry, as David Qualls likes to say, as a profession, and we get great professional satisfaction out of what we get to do every day. And it's a shame that other people don't know about our profession, that they want to also apply and become these. Getting the pipeline in your communities primed for applications into PTA or PT programs is important. It's a community service. So having even junior high age kids who are thinking about their career, because now dual enrollment is a thing in high schools. Many high school kids, by the time they're juniors and seniors in high school, can also enroll in a local university or college and get dual enrollment credits. So they're thinking as junior high schoolers, what direction do I want to go? Okay, I want to go in healthcare. Well, invite them into your clinics to shadow, to learn how incredible it is that you get to invest in people's ability to move and participate in life. That's the hook, to see what your relationship with your patients are. And so they make those decisions in junior high and early high school about their career path. And we want the best and brightest to continue to join us in this profession. So thank you, Jane, for your energy around career ladders and credential stacking, because I think there's a lot of PTAs who are in our profession who would like to continue professional development into the PT career, and we need to make those pathways available.
Yeah, I just have one quick question, and we're closing up. When you said some people are saying, hesitate, hold on that for a second, are you talking about going into PT, or are you talking about the hybrid programs?
No, going into PT, period. Some people are not advising students to go into the profession. And I know that it's related to debt burden and payment stagnation, but we can't reduce the future of our profession to what the current challenges are. We have to tackle the current challenges and bring the next generation in.
Yep, for sure. Because I talked to some folks at CSM, and they're really having great success with hybrid. They're like, it really, for the right students, they are just loving it, teaching it. The students love it. So, I think if one thing came out of COVID, that's a real positive thing, because I don't think we thought we could ever teach physical therapy school online, like, because that's how we are. Oh, we couldn't do that. But guess what? We're doing it, and we're doing it well, I think. So I think that's great progress, actually. And I don't think we're going to start the hybrid program for PTAs, but somebody should. I love that.
Well, thank you for calling that out, Jane, because I think coming into this session, what I was seeing is a lot of negativity online, and they're unfortunately louder than the positive, encouraging comments. So hopefully, one of the things that we can take away is getting in front of students earlier and earlier, and I think junior high or even sooner than that.
Mhm.
I was introduced at 14, so this is the only thing I've ever wanted to do. Okay, I put the contact information for both of our guests in the chat. Thank you, Tara and Sharon. I really appreciate you sharing your expertise and taking the time to do this. Our next call is going to be focused around financial management. The registration link is in the chat. That'll be with Sterling Carter. And then we have Amy Lafko for leadership in April. So I hope to see everyone every fourth Thursday at 1 o'clock and make this a recurring thing. If anyone is here for the first time and willing to stay on for 2 minutes and just give me your quick 30-second feedback of what you thought of the session, that would be really appreciated. But everyone else, thank you and have a good rest of your day.